Hi, I'm Jessica Page. This is Journal Club 1. My article is entitled Differential Diagnosis of Bipolar 2 Disorder and Borderline Personality Disorder. And it was published November 20th, 2019 in Current Psychiatry Reports. I found it on the Duke Library website, but it can also be found in PubMed, or even a Google search will yield multiple websites with the article. The authors of this article, Adam Bays, Gordon Parker, and Joel Paris, sought to examine recent studies that considered clinical differences between bipolar 2 and borderline personality disorder, which might help to advance their delineation. I chose this article because in clinicals, I have had multiple patients with bipolar 2 disorder diagnoses who the clinician thought likely has borderline personality disorder, and I was interested in distinguishing in the differential diagnosis and being able to distinguish between the two and why it's difficult. And so that is how I came up with this particular differential diagnosis article. The authors examined a lot of recent studies and found that some of the features are helpful in determining and distinguishing between the two, and some are not. I'll go over the ones that they found that were. Also, another reason that this is such an important thing to be able to distinguish between, obviously, is because of treatment. Patients, particularly who have bipolar 2 disorder, delayed treatment can really make their symptoms worse. Can increase the risk of mania, severe depression. So treatment is really, you want to be able to figure out the diagnosis and treat. So the first one that they found were differences in mood states was a helpful way to delineate. Depression and hypomania were both helpful to figure out, which is which. And affective instability. These are all kind of parts of the mood states. And in bipolar 2, these things are typically internally spontaneous. They come from within. Whereas with borderline personality disorder, they are often in reaction to interpersonal stressors. As with emotional regulation, same thing. Borderline personality disorder tends to have more maladaptive cognitive strategies. Heritability was another helpful feature. Studies do show that a family history of bipolar disorder supports a bipolar 2 diagnosis rather than a borderline personality disorder. Onset and clinical course are also helpful, or illness course are also helpful, excuse me, in differentiating. Bipolar disorder typically has a distinct time of onset and worsens with age, whereas borderline personality disorder doesn't have a clear starting point and often improves by middle age. Excuse me. Again, mood state, they broke it down into separate things, but all of the mood differences in mood states made it easier to distinguish between the two, or were helpful to distinguish. Excuse me. Childhood trauma. Excuse me. They looked at childhood trauma, and though both disorders have a higher rate of childhood trauma than the general population, sexual abuse is a strong predictor of borderline personality disorder, and that suggests that the type of abuse can be helpful in differentiating. Relationships, relationship factors is also a big one that can be a big feature that can be helpful in diagnosis. Borderline personality disorder causes more difficulty with relationships. People with borderline personality disorder tend to avoid relationships due to fear of rejection or abandonment, whereas bipolar 2 disorder does not make it as difficult to maintain relationships, particularly when the patient is euthymic or when the person is euthymic. Psychotic features and dissociation are key features of borderline personality disorder. About 75% of patients have that. Bipolar 2, by definition, lacks that during hypomania, but it is possible to have psychotic features during depression in bipolar 2, but it's very rare. So that is another feature that is often indicative of a borderline personality disorder diagnosis. So they also found, multiple factors that have been looked at in studies that are not helpful to determine, such as some of the biological parameters like genetics, epigenetics, diurnal rhythms, structural and functioning neuroimaging. There are some differences that they found, but they're not sufficient yet to be able to help guide any sort of diagnosis or treatment. Some of the other factors to impulsivity, neuropsychological profiles, gender distribution, being female or male, comorbidities of drug and alcohol use, or response to treatment. Those things aren't really useful in distinguishing which disorder is present. Let me see here. Also, suicidality and deliberate self-harm. I think a lot of people think about that as BPD, but the authors found that, it's pretty common in both, so it doesn't really help to determine which disorder is present. Let's see. So they discuss the DSM criteria and say that each are differential diagnoses for the other. So bipolar 2 disorder is a differential for borderline personality disorder and vice versa. However, the DSM doesn't really offer any relative specificity of the features of each, so there's no weighted import to any of the features. So it kind of makes it more difficult to delineate between the two. Let's see. The screening tool, they discuss the mood disorder questionnaire, and found that screening instruments can be of value, but they kind of have to be, used kind of with a weighted features, like I was discussing before. Like there needs to be weight placed on certain features. The personality inventory for the DSM-5 found the borderline personality disorder algorithm was moderately accurate in differentiating bipolar spectrum disorders from borderline personality disorder. They do talk about the personality inventory for DSM-5 borderline personality disorder algorithm that is in section 3 of the borderline personality traits. They showed moderate to excellent accuracy in differentiating the disorders. So they, kind of suggest possible dimensional approaches to borderline personality disorder as an alternate method of evaluation, but they're not sure if it'll be helpful clinically yet because it hasn't been done. So they say clinical acumen is critically important, which is, kind of what everybody would like to achieve. But an examination beyond the symptoms is important, with focus on non-symptom features to improve accuracy. So there was a large head-to-head comparison study of individuals with BPD or BP, and they found key differences across diagnostic validators, which favored a borderline personality disorder. So history of childhood sexual abuse, depersonalization in childhood, personality features related to relationship difficulties, and sensitivity to criticism, as well as an absence of a family history of bipolar disorder, yielded a 92 to 95% accuracy in the diagnosis. And basically, they suggest an approach of assessing whether a bipolar 2 condition is present or absent, with weighting of the features specific to bipolar disorder. And secondly, assessing for the presence or absence of a borderline condition with a weighting toward developmental trauma, as well as borderline features. So they really think an approach of weighting these features versus kind of giving them all the same amount of importance to, just kind of check boxes would be important for better diagnosis. And then they discuss the management approaches. And that, with borderline personality disorder, it would be psychotherapy would be the treatment, and then bipolar disorder would warrant pharmacology treatment. In the presence of both would warrant treating them concurrently or starting with the most severe, typically bipolar, and treating that first and then treating the borderline personality disorder after that. They discuss the limits in research, specifically lack of head-to-head studies between the two, between borderline personality disorder and bipolar 2. They think it's, really important to be able to recognize hypomanic symptoms, because that would be sufficient to diagnose a bipolar 2 disorder. But when that isn't present and obvious, that you need to look to the other features that are indicative of specific disorders to be able to determine. And I think that it was a very thorough review, very long. I apologize for going over my time and keeping you. I felt like the article was clear. A lot of the information in it is really good. I think in the clinical setting, it can be difficult sometimes to glean that much from the patients in a short period of time. Though I think a really good history from the patients is important, particularly around relationships, family history. I didn't see any real problems with the review itself. I agree that there need to be more bipolar 2 and borderline personality disorder studies where they're head-to-head. Also, a lot of the studies in here did not distinguish between bipolar 1 and bipolar 2. And so I think the authors didn't really use many of those studies as, helpful in determining and distinguishing between the two, which I think is good. So I think there need to be more studies with specifically bipolar 2 compared to borderline personality disorder. But otherwise, I thought it was a great article. It was very long, and this was very long, and I apologize. Thank you.